Thanks, Ben and Ajita, for having me here. As Ajita said earlier, there's some buzzwords around here, so I want to define high reliability, and that I look at as a practice that has proven high quality and is reproducible. And then what does streamlining mean? Well, for me, it's referring to a narrow focus. And in our case, it's a couple diseases. And so before I dive into the talk, I want to give a tiny bit more background on my practice, which, as Ben said, started as a solo private practice. I've been in group practice, and I'm solo again. I started doing all of general surgery, including lap Nissens, lap colons, lap choles, appies, and over 18 years of practice, I've slowly narrowed my focus. And each time I narrowed my focus, I got busier at what I kept doing. I got better at it and had more fun. And now I only do ambulatory, mostly inguinal hernias and pilonidal surgery. So, how am I advancing this? What did I do? Oh. It's not. So here's my 7-second disclosure slide. Really is that I am in a private practice, and I'm going to give some examples of real life of how we are operationalizing our practice as it relates to quality and defining quality. So I want to go over a little case study and bring up Shouldice Hospital again as a reason why to streamline. I want to challenge the view on quality a little bit and then see if this is something that you think you can do in your own practices. So, the Shouldice Hospital gets a lot of attention, mostly in business case studies, but some in medical case studies, as you saw in a previous talk. They have one thing that stands out. They have reproducible, high-quality outcomes in a very narrow focus on select patients. But they've been able to reproduce it for 70 years and across generations of surgeons. And they rigorously studied their outcomes, changed their procedure, and maintained very narrow control of what happens there. And I know this model is not going to work for everyone. The term general surgery is almost counterintuitive to what is done at Shouldice, but I'm hoping that you think about how can this be done in your own practices, because I believe that this model improves the outcomes for the patients, but it also increases satisfaction for the providers doing it, and ultimately it reduces the cost of the healthcare we deliver. And so, for a long time, I looked at the left side of this picture as the definition of quality. So outcome measures, patient safety indicators. And it really wasn't until I went to business school 4 years ago that I started looking at the right side, the part that all the hospital administrators talk about, and started thinking, is this an important part of how we define quality? And there isn't a lot of literature about the patient experience and how it relates to outcome, but it does get mentioned in the New England Journal of Medicine, the British Journal of Medicine, and even JAMA, and it's a little hard to see, but one of the common themes is that the trust and communications that patients have with providers and the relationships actually affects the quality scores of even hernia surgery. And so I want to spend a fair amount of this talk sort of looking at quality from a different lens. There are tons of variables that are important that we need to measure, and I'll talk about outcomes data. But what's important from the patient perspective, from the people paying for the surgery, the payer perspective, and then our healthcare system in general. And this is a work in progress. Our views are always changing, so I welcome feedback at the end of what you think. So outcome measures, I think, are critical. I think the America's Hernia Society Quality Collaborative, and I'll put in a plug for that because it's provided our practice a tool to capture patient-reported outcomes, but also hospital readmission rates, reoperation rates, and it's telling us where we're outliers, both for good and bad, and it's the one way our practice can continually to improve. And so when we built our focused clinic, we hired medical assistants, and part of their responsibility is to getting patient-reported outcomes data before every appointment, after every appointment, and to call patients for follow-up to capture, to make sure that we get as close to 100% as we can. The other thing that we've been able to do with the Quality Collaborative is implant tools within the database to capture opioid prescribing and utilization data, and hopefully use those outcomes to influence opioid prescribing through the collaborative and hopefully reduce the opioids that are used. So I'm going to switch gears a little bit and talk about patient satisfaction and a patient experience. And I reviewed some of the literature that I could find, but I also hired a marketing company to survey 20 of our patients and understand from them what they're looking for. And what's fascinating is that universally patients wanted information. They wanted information before the surgery of what the surgery is and also what to expect after surgery. Patients want a lot from us now. They want written instructions, they want videos, they want phone calls, but they want us available, it seems like all of the time, and it's a fine line and a balancing act. But they want more and more of our time. And so how does one create more time to meet the patients where their needs are? And in our practice, we did it by establishing the relationship. And this is kind of, I think, answers the question that Ben asked in the last talk is how do you operationalize this? And for us, it's about creating a team approach. It's not about the individual surgeon, it's about the team. And so we've hired medical assistants who we've brought into the operating room multiple times to observe surgery. They've been in the consultation rooms numerous times to see exactly how we interact and how we teach what we do. We also have a physician assistant that has assisted in over 1,000 hernia operations at this point and evaluated several thousand patients with growing pain. And so each one of us in our practice is practicing at the top of the license. It means that the patients, whenever they call, they're getting somebody with an area of expertise. And I did this by borrowing a page out of the book Drive by Daniel Pink about how do you create the environment that's increases motivation. And there's 3 factors that are critical to get that intrinsic motivation out of your employees and out of your team. The first one is mastery. And by training our staff to really become experts in inguinal hernia, we're getting them to the level of mastery that's hard to replicate. A sense of purpose. As we saw earlier, the recurrence rate and chronic pain rate are incredibly high. And we see those patients come in with complications all the time into our practice. Our single purpose is to avoid that. And so by measuring the outcomes, by having a single purpose, we're achieving 2 out of the 3. And the last part is autonomy. When you have staff that's trained, you can trust them to give their own flavor into their interaction with patients. And so a couple nights ago, my medical assistant texted me at 8:30 at night saying, I've put in 25 patients into the database for the Quality Collaborative, and only 2 out of the 25 actually filled their opioid prescription, and they use 1 to 2 tablets each, yet you prescribe 6 to 10 tablets for every patient walking in. Can we talk about ways you can change your practice? And so when your medical assistant feels empowered to make changes in the practice, I think we've achieved sort of that internal motivation and drive. And I think that's really critical of establishing that in a practice. Decision-making efficiency is something that comes out of the business school talk about quality and reducing cost as it relates to efficiency. And in our practice, I surveyed the last 4 months of inguinal hernia symptom referrals. Not all of those were diagnosed as hernias, but only 84% actually had a hernia on exam. 16% we diagnosed with an abdominal strain and sent to physical therapy. While this isn't as critical to the individual patient that we didn't order studies, but by focusing your practice, you can skip laboratory tests, CAT scans, ultrasounds, and help the entire system. So finally, this is kind of the most touchy-feely, and I think it's probably the least important part in some ways, but when you think about parking, in our last practice, patients routinely used to spend 20 to 30 minutes looking for a parking spot for a 30-minute appointment. When they come in stressed, it is really hard for them to learn about their disease process, to be confident that they're learning and leaving well taken care of. And so you got to think about things like parking in your own institution and also aesthetics. Obviously, your office has to be clean, but if you have a welcoming environment, the patient can actually concentrate on what they're doing and why they're there. And so I think that the hardest part is, have I made you think about ways that you could streamline or given you any ideas that you can streamline in your own practices? I think if you're interested in doing that, the first step is to create sort of a focused clinic within a practice and department and train others. And that involves creating a team approach for taking care of a specific disease. I think there's a lot of challenges to something like this, partly as you have to have enough volume to focus, and in some areas, depending on where you come from, there may be a lot of or low population density, so there's not as many patients. There may be market competition. And then finally, is this something that you're motivated to do? Because streamlining is not for everybody, but I want to challenge you that by streamlining, you're actually building a lot of value for the patients, but you're also doing it for the providers that are taking care of that patients, and you're improving the healthcare system at the same time. So with that, I'll stop, and I guess questions at the end.
And we're going to ask you to stay up here with us, please.
Right.
Thanks so much,
Thanks.
Micki.